NODA is here.
Okay.
It's great to have you here. So
Thank
we
you.
would like to start. Sorry, guys, for keeping you guys waiting so long. So today the topic is standardization of diabetes treatment, as you know, and I hope you all received the concept note. I'll explain a little bit of the background. So as you know, November 14th is marked as the World Diabetes Day to raise awareness across the globe about the burden of diabetes and complications caused by the disease. So in Pakistan, 33 million people are affected with diabetes. And it is ranked third in the number of people with diabetes following China and India. And it is the highest in its prevalence in the world as well. So in spite of this situation, the number of experts have been gathered here. And then we would like to discuss the situation. So a little bit of the background is about 2 years ago, Dr. Zafar Mirza, he is a former special assistant to the Prime Minister on National Health Services in Pakistan. He had the growing sense of crisis about this issue. So he had a talk with former ambassador of Japan, Kuninori Matsuda, and then he passed this request to our current ambassador, Mitsuhiro WADA. Yes. And then now, so the request has been communicated with Professor NODA. So he is a long-term expert who has made significant contributions to diabetes treatment and research in Japan. So it is great to have Professor NODA here, so he can provide a great insight and knowledge and his intake on standardization of diabetes treatment. So I would like to move on to today's agenda. So now we will begin by opening by our ambassador, His Excellency Mitsuhiro WADA.
Hello. My name is Mitsuhiro WADA, Ambassador of Japan in Pakistan. Dr. Mitsuhiko NODA, Professor, International University of Health and Welfare, Ichikawa Hospital, Japan. Dr. Ibrar Ahmed, President, Pakistan Endocrine Society. Dr. Syed Abbas Raza, President-elect, International Society of Endocrinology. Sorry about the distinguished guests, doctors and experts. As my colleague explained, that this idea, the webinar date back to the autumn of 2019, when Dr. Mirza, then special assistant to the Prime Minister, requested my predecessor, Ambassador Matsuda, for the cooperation. And in the meeting, Dr. Mirza highlighted that diabetes is a national disease of Pakistan and asked Ambassador Matsuda for technical support from Japan. Professor NODA, who is here today as our lecturer, is a renowned doctor on diabetes and also the brother-in-law of Ambassador Matsuda. I'm very happy to address today's webinar, which is connected by such an interesting coincidence. I would like to express sincere gratitude to Professor NODA for taking time out of your very busy schedule to prepare for and attend this lecture. This year, Japan and Pakistan are celebrating the 70th anniversary of the establishment of diplomatic relations. In the history of Japan's development assistance to Pakistan, health has been one of the priority areas, especially maternal and child health and routine immunization, including polio eradication effects. JICA has also sent experts to the medical field here to provide guidance on moderate intake of salt and sugar, as well as balanced nutrition, which I believe is contributing to the prevention of lifestyle diseases. The partnership between Japan and Pakistan has been diversifying in recent years. This webinar is also an innovative attempt to directly connect doctors from both countries. I hope that this webinar will serve as an opportunity to further expand and deepen the partnership between Japan and Pakistan. Finally, I would like to express once again my deepest gratitude to Professor Noda for joining far from Japan, as well as to Dr. Raza and Dr. Ahmed, who worked hard to organize this webinar. Thank you very much, everybody, and then I hope this webinar will be meaningful for all the participants. Thank you.
Thank you, Ambassador. And now we'll move on to Dr. Ibrar. Ahmed, President of PES, over to you.
Thank you. Bismillah ar-Rahman ar-Rahim. First of all, thanks, Ms. Wazir, for introducing me. Secondly, I welcome all the participants of this webinar, especially His Highness Mitsuhiro WADA. Sorry if I spell it wrong or see. Thank you, and I'm also thankful to Professor Noda and Dr. Abbas Raza for joining and for giving. They will be giving a talk regarding standardization of diabetes care. I must thank Dr. Abbas from Pakistani Endocrine Society, and he was from our side in the forefront and in negotiation and in managing this educational activity. Regarding coming to the diabetes care, as we both
recording in progress
from different regions, Western specific, or we are in MENA region. If we look at the prevalence of these both regions, more than 80 million people of diabetes are residing in these regions. And as mentioned previously, Pakistan is at number 3rd with more prevalence of 32%, and Japan having a good prevalence of 8.8 regarding recent IDF data. If we compare both of them, the expenditure which is spent in US dollars on diabetes healthcare per person is about $80 in Pakistan and about more than 3,000 US dollars in Japan. If we look at this, that if we move on this space in 15 years time, you will be jumping to 8.3%, and we will be jumping to 34%. So if we do some calibrative work, it will be helpful for our region also. So through this webinar, and this is the initiation, and Pakistani Endocrine Society, as I'm nowadays president, I'm fully supportive that in the future, if we work and calibrate on government front, on the society's front, we can move forward. If we look at the previous history, that from this comprehensive care, how we can go for standardization of care, it is through research projects. So I think that Japan, the doctors, the researchers there are doing good work, and they are working on different molecules which are helping in the management of the diabetes care. So we, as Pakistani Endocrine Society, as Pakistan, we want that we should calibrate on that front also. Regarding our prevention, to prevent this diet, the preventive care, I was looking at the preventive care of Japanese in previous days. So the food, the sedentary lifestyle were the main causes they were taking care. But in our community, after COVID-19, after this, in my opinion, the food starvation will be the major problem, because we will be diverting toward the unhealthy diets, and it will create some problem. So I need, because as Excellencies ambassadors told us that they are doing different projects in maternal child healthcare, in immunization. So we will be looking forward that if non-communicable diseases should be taken at front, and we can calibrate further. So I think that in next 1 hour, standardization care can give some knowledge to our participants that what we are at par, we should get some knowledge and experiences being shared. So inshallah, we will be looking for much more calibrative moves and workshop, seminars, webinars, and projects also. Thank you.
Thank you so much, Dr. Ahmed. And now we will have Dr. Raza, and he is currently the president-elect in International Society of Endocrinology, ISE. Could you introduce a little bit of yourself and then move on to your presentation? Over to you.
Thank you very much. Again, it's a great honor to be part of these Pakistan-Japan relationship celebrations. And again, as Ibrar has mentioned, we are trying to collaborate not only in right now, but in years to come as far as fighting this epidemic, which is affecting both Japan and Pakistan. And I'm very happy to have Dr. Noda here, who's going to talk about Japanese perspective in light of Pakistani background as well. So without further ado, I'll go ahead and start my presentation as well. Thank you. At this time, I'm honored to be representing Pakistan Endocrine Society, where I've worked as the past president and also currently holding the position of president-elect of International Society of Endocrinology. So it's indeed a pleasure to be here and to be addressing most of the people in Pakistan who are being connected through this platform from different institutions and different medical colleges, as well as university hospitals. Thank you again for the organizers for having me here. Without further ado, I would just directly jump into the topic of the day, which is understanding the concept of diabetes management in Pakistan and how we can work our way towards a better management of diabetes in this part of the world. Hence, I would kickstart with some basic outlines of the program, which includes just the first section. I'll be dissecting the ground realities of what's happening in Pakistan and some similarities and differences between the management and the prevalence of diabetes between Pakistan and Japan. The second portion would be on current practices and what are the challenges and the difficulties that we find in most of the global world, especially focusing on Pakistan. And lastly, the impact factors which can actually make a difference as far as when we're talking about management of diabetes is concerned. So let's start by the ground realities of Pakistan. This is the graph that most of us have seen. And again, I would like to focus on this part of the world in which is the MENA region, Middle East and North Africa region. The IDF has recently published this map in which Pakistan is placed in the MENA region. And if you can see in the percentage increases in most part of the world, we are actually leading along with the Africa as far as the increase in the incidence of diabetes is concerned. Japan is also increasing, but again, obviously, it's not as rampantly as compared to Pakistan. So that's one difference that we would want to address here. If you look at this map, which is very interesting in fact, because Pakistan was actually not even the top 10 a few years back, but we have jumped from top 10 to top now. We are number 3 now in diagnosed and number 4 in about undiagnosed patient with diabetes. Japan is consistently showing up as number 9 in diagnosed in a certain age group as well as undiagnosed. All the prevalence rates of Japan are relatively, and again, our worthy professor will be discussing it later on, but there is one big difference between Pakistan and Japan, and that's the age-adjusted comparative prevalence. As most of the Pakistani population is in the younger age group, if you look at the age-adjusted comparative prevalence, Pakistan actually is among the top as far as the number of patients in a specific younger age group is concerned. This is in difference with the Japan, which you'll see because of the growing age of the population, you'll see more people with diabetes, and that's just because the prevalence of diabetes is higher in older age. So again, that's one difference that I would want to point out, that in Pakistan, their age adjusted comparative prevalence is much higher, and the younger people are getting affected. And again, the number is going to grow much faster than any part of the world. Another astonishing factor is that this number is not going to deteriorate over the next 20-25 years, and we're going to continue to increase the rate of diabetes, which is sad in a sense, because the younger people, when they grow old, there will be more diabetes in years to come. And the other factor that I would want to point out is that we are at the top numbers as far as the death related to diabetes is concerned. Pakistan has about 29% of total deaths associated with diabetes, which is comparative to Singapore, but unfortunately we are among the leaders in that perspective. So the question arises when you're dealing with situations like this: what does it mean for the patient, and what's the patient perspective? For me, it's important to know, and again, I think audience is important to know, that the management of diabetes is between the healthcare providers, healthcare system, and the patient. And I'll describe it to you in a systematic way in the next 10-15 minutes. Let's focus on the patient. For patient, it's not a single disease. So we used to call diabetes as diabetes, a sugar problem, but now we know it's an omnious octad. So it's not one disease process which is being effective. It actually involves the increased insulin secretion, it involves the hepatic glucose production, it increased lipolysis, and obviously decrease incretin effect. So again, without going into details of it, it's not a single disease process that we are looking at, or it's a complex or integrated disease process which you have to do. So what are the challenges for the patients when they go through this? It's actually there's this multi-prong. So there's one fear within the patient when they're diagnosed with diabetes. It's the fear of the needles that's coming along the way. It's the fear of hypoglycemia, weight gain, obviously taking the medication on day in, day out for the rest of your life. Feeling of failure, that even though you're doing your best, but still the disease process gets worse over a period of time. That's something. The cost associated with it. Most of the Pakistani population is this out-of-pocket cost. But again, some of them are supported by government too. But again, cost ultimately pays off, not only in the form of medication, but the complications associated, the days which are not, when you cannot work because of the complication of diabetes. So these are one of the few complications. But there are also barriers for the optimal treatment. And I'll show you one of the examples. Pakistan is a huge country as far as demographics are concerned. The other major factor that you can see, that each province has one major, if you can see my arrow, has one or two major cities within the province. Why is it important? The importance is that if you look at the endocrinologist ratio and the time you need to travel, and again, when I talk about possible solutions for this, I'll talk about these distances as well. So for someone who's living in an area which is about 200 or 300 kilometers from the area where they can get the specialized diabetes care, it's like a 2-day journey for them just to see a consultant or an endocrinologist or a diabetologist for the management of it. So these distances are not comparable to most of the foreign countries. Like even if in US, you don't have to travel for more than 20 miles in most of the cases to see a specialist. So hence, that's something that we need to look into it when we are trying and managing the impact of it. And please remember, we'll have to find solutions as we go along for it. The second section, when we are dissecting this problem, is the current practices. What is the specialized care? What is the art of management, and what is coming along? And this is what I was talking about earlier. If we look at the number of people who are trained as an endocrinologist or diabetologist, the number is not more than 300, 400 in the country, which has a population of about 220 million. So if you look at the diabetes specialist to one person who's trying to get a specialist care is about in millions. So hence we prove, and again, this is true for most of the world as well, that every diabetic does not need to be seen by a specialist, which is an endocrinologist or a diabetologist, but we need to have the capacity building of the physicians who are seeing in the front lines to take care of diabetes and take care of the problems the diabetes patient would be. And again, the specialist care should only be referred for the people who need help and who are not being able to be managed by because of the complication or other factors in these in outskirts of the bigger cities. So that's something that we need to look into. Why is it called still the art of medicine? And obviously, we need to look at it this art because we need to not only treat the blood glucose of it, but we need to also decrease the complication of diabetes. There's a whole set of problems. As I mentioned when and I initially talked about Omnius Octet, it's not only treating diabetes, actually. It's taking care of the A1C, it's taking care of the activity, developing a program so the patient can exercise, it's taking care of the blood pressure, it's taking care of triglyceride, HDL, LDL, and cardiovascular complications. So it's a much more complex problem just to taking care of a single problem that we deal with. And it's not over with just the complicated problem itself. We learn on a consistent basis. And here I show some of the guidelines which have been published by the American Diabetes Association. I'm not going to go in the details of it. But again, if you look at it over progression of time, in just last 5 years, there has been a significant shift in how you manage diabetes in this, or what is recommended to be used as a first line for management of diabetes. And with the passage of time, I think the focus is shifting from just the medication and lowering down the blood glucose. It is actually shifting towards a better control with a better A1C, keeping the patient's comorbids and other medical condition in the center of the disease process. So that's something that we need to look into when we're deciding. So this makes everyone's life a little bit more difficult. And this is a very interesting slide. I wanted to show it to you. And if you look at the graph, the A1C in the real life versus in clinical trials. So when we're doing clinical trials, we have a multidisciplinary approach. Everyone gets involved, the doctors involved, nurses involved. But when we lose that in a real life, the A1C tend to go up. That's important to know because this is the real life. These are the patients that you're seeing. So to many of these patients, we need to develop an algorithm in which we are not only treating them, but we are treating them in a way that we're treating them as they are in the clinical trial or as close to as they are in the clinical trial so that we can manage them better and again, treat them better in a better way. How can we actually do it? There are multiple ways about it. There's a role of the endocrine societies, there's a role of diabetes societies, and obviously there's a role of how we can manage our patient with diabetes. How does it? Again, looking back in our healthcare system and different perspective of the healthcare and management of diabetes, now let's focus on the healthcare providers. And this is one of the more important things that I would want to discuss. It's the patient with type 2 have to be treated proactively. And this, if you look at this graph, if you see it, the orange part is the people who have any change or intensification in their regimen. They are in orange, and the blue are people who did not had any change in the regimen, even when their A1C was more than what is recommended by most of the organizations. What do I mean by that? It's an A1C which is more than 7, and we need to look at how many people are being treated aggressively for it. And interestingly enough, and this is where I would want to stress, this is data from different pool of patients, and you can see unless their A1C is more than 9, they are less likely. So again, only if their A1C is 9, 60% of them patients would have intensification of medication. But if you look at the rest of the A1C, the chances of intensification is actually 1/3 if your A1C is 7. So again, as physicians, we were not proactive in intensifying when we actually need to. So if your A1C is 7, we should have, in an ideal world, everyone should have moved toward intensification of medication. But in this case, you can see about 1/3 of the people, actually 2/3 of the people, don't not get their intensification in treatment when we're looking at intensification of treatment. And this data is pretty much universal. If you look at any data, any region, most of the time the proactiveness of the treatment does not happen. And what does it translate to? It translates into more complication, it translates into more sick days, it translates into more socioeconomic burden on the patient as well as the society in general as well. So that's one thing which is very important. The other important part when we talk about intensification is that if you make the regimen simple, it's easy to and this graph actually shows that if your A1C, if you're taking just one tablet a day for your diabetes, you're more likely to be intensified, or you're more likely to be treated with aggressive management if your A1C is higher, if you were using one or two medication. But if you're taking more than two medication, the intensification by the doctor becomes lesser. So my lesson learned here is, number one, we need to be proactive in treating. Number two, the most important thing is our treatment regimens should be easy to use, and it should have a protocol. Because if you look at the ADA guidelines, the options of treating are so many that sometimes when a physician is trying to figure out, especially if someone is practicing a general medicine and they have multiple disease process and a diabetes person came in, and if they don't have a team, it becomes difficult to have them in a process that they can think, decide the best appropriate next medicine, and take care of the A1C. So again, easier medication. Number two, proactiveness, and the algorithm should be very clear. And if we can, in the ideal world, if we can journalize what will be your first pill, what will be your second pill in about 90 to 95% of the people. So it will become easy. You see an A1C, you just see what the patient is taking, you go to them. And that's actually my work, which has been happening for the last 2 years. And I've been focusing on this. This only has an socioeconomic benefits. Obviously, it reduces the cost of the complication, and obviously more better treatment if you standardize the treatment. Obviously, the insufficiency of medication can be easily overcome if you're dealing with this. Another important factor is medication possession ratio. And this is the reason I'm telling you, this is data from 2016, but I must tell you that if we have looked into different studies in which we try to figure out, we always think that the doctor, if they tell the patient, that's the only way you can get the benefit to the patient. But actually, adherence is usually not affected by whether medication is obtained from the physician or the pharmacy. What it tells us is that if we have a team, even if you cannot spend another 15 to 20 minutes with the patient describing the medication, you can have a team member who's probably not endocrinologist, diabetologist, even a doctor. They could be a pharmacist who can explain the medication and get and better response as far as treatment and keeping the medication and follow-up is concerned. Diabetes in general, if you can see, medical possession ratio is not that great. Medication possession ratio usually tells you that how much patient is complying and how much stock of medication he's taking and how much of the medication he's taking. In diabetes world, it's in about 1/3, 1/4 of the people do not follow up and do not have enough medication for their follow-up and proper management of diabetes. So something to do. So we have learned 2 or 3 major factors. It does not have to be a doctor explaining everything. Doctor has to be proactive, and number 3, the regimen has to be simplified. Let's look at the healthcare system. And again, this is how I would want to finish my presentation as well, that we have learned in the previous years, especially during COVID time, telemedicine works. And this is somewhat of a recent article published in January 2022 in the Annals of Internal Medicine, in which they found out that the telemedicine works just as well as patient care and management of chronic illness. So you have a set of people who have chronic illnesses. You can see them physically once, but you can have them followed up by the telemedicine over a period of time. So that's very important. The reason I say it's very important is that we need to figure out ways how to deal with the patient, especially in a situation like Pakistan, in which the traveling time is so much. And this is what I was referring it to you earlier. And the other factors are so much. And the cost of traveling and the cost of seeing a physician is so much. We have to cut down on the cost as well as the traveling time, as well as the availability of the specialist when you're living in an area where you do not have a specialist. So again, a general physician should be the primary care physician. He should be taking care of diabetes. but the accessibility of that is it should be made easy for the people who are seeing it. In the same on the same lines as I was mentioning it, again, I've been working again just as many examples which are happening in Pakistan. One of the examples that I've been working on has been a Dream Diabetes project, which actually encompasses a project in which you provide a platform which is accessible. So during the COVID times, I used telemedicine a lot during this time. And again, I found out that people did not have to travel hundreds of miles to come see me, and they were very well taken, and their A1C actually improved significantly by just being available on the telemedicine for complication, and they've been following up with the local general physicians which are available here. So that brought me to a point where we can do something in a project like Dream Diabetes or any other project that you would want to work in which you can provide them a platform where you can provide them specialized care and get the connectivity between the physician and the consultant and the diabetes educator as well as the patient all in one platform, and maybe we can get better education and better medical care for these people with suffering from diabetes. Obviously, the objective is to keep a close environment in which all of us can reach out to each other and get the platform. And it's successfully been completed 2 years. We're going nationwide in months to come, and I'm hoping to enroll more general physicians who are willing to come and join this platform so that we can get the message out and again get the best of the care without adding too much financial burden on the patient actually, who wants to be taken care of and also wants to be well aware of the disease process. So the connectivity between these people are very, very, very important. And again, we can, in this time and age, we can definitely do it through our system. So summarize, the ground reality is that diabetes is prevalent not only in Pakistan, but across the globe. We have, but unfortunately, we have the highest growing rate as far as the people suffering from diabetes is concerned. There are some similarities between Japan and Pakistan, but there are definitely technological advances and other modalities which are again different in different countries. We can definitely work together between Pakistan and Japan, Pakistan Endocrine Society and Japan, to learn from each other. And in the series of that, we are having this meeting. And again, we will learn from our worthy professor from Japan. And then we will share the experiences of how we can do a better job. Obviously, the current practices and the future direction I've already mentioned. We need to be using more of technology, artificial intelligence, machine learning, as well as integration of the triangle of the patient care as far as for getting the better benefit of transforming a diabetes care to a general physician, which is translated into better care of a diabetic patient. With that, I thank you all for your attention, and I'll stay tuned for if there's any question in the chat box or in the question answer session, and I'll be happy to address the question. But my talk is followed by our Japanese colleague who's going to enlighten us with standardization of treatment, and I'll hand over the mic back to the moderator. Thank you very much.
Thank you, Dr. Raza. Thanks for starting from the concept of diabetes and also providing the current landscape and offering how we can enhance this practice. As we know, it is critical to be aware that diabetes is not only single disease, it is interlinked to various other kind of complications. And it is very informative to know the challenges such as the extensive traveling time required to see the specialist, and also there's currently insufficient number of available specialists, and hence there's a need for capacity building, and understand there's a need also for integrated programs. And it's also interesting to know the focus has shifted from the simply providing medications to better control, meaning prevention. Because the prevention prevent complications, which leads to reduced cost. I agree with that. And also on that note, it is essential to provide proactive and timely management, especially with the standardization of treatment. So thanks for your input. And then now we will move on to Dr. Mitsuhiko NODA. He is the professor in the Department of Diabetes, Metabolism, and Endocrinology at Ichikawa Hospital at International University of Health and Welfare. And floor is yours. Over to you.
Oh, may I start?
Thank you. We will do that.
Yes, please.
I'm pretty much honored to be here and to be involved in this project. And I would like to I appreciate very much for all the members involved in this project. So please start my lecture that I have recorded a week ago.
Thank you. We will do that.
First, I would like to express my sincere gratitude to all those contributed to and involved in this webinar. Today, I will make my presentation under the title of Standardization of Diabetes Treatment. This is my conflict of interest. I have nothing to declare. I have been planning to make today's presentation in 3 parts as shown here. First, I would like to introduce the trends of diabetes in Japan and in the world with brief mentioning to Pakistan. Then I would move forward to mention the representative outcome trials performed in Japan, the JADE3 trial, which dealt with cardiovascular outcomes and mortality of patients with type 2 diabetes in Japan. Lastly, I'd like to talk about standardization of diabetes treatment in Japan by introducing the Standard Diabetes Manual for General Physicians, which has been developed by the Japan Human Data Society of Diabetes and Related Diseases, for which I myself is chairing the representative director. Let us go to the first part, trends of diabetes in Japan. This slide shows the countries with the largest number of adults with diabetes and aged 20 to 79 years. This is from the IDF, International Diabetes Federation Diabetes Atlas 10th edition that was issued last year. As you can see, Japan is listed as the country with the 9th largest number of people with diabetes in the year 2021. And Pakistan, the 3rd. Pakistan is estimated to be also the 3rd place in the year 2045. However, the absolute number would be greatly increased in that year. As you can see in this slide, as for diabetes prevalence in the adults, that is population adjusted prevalence data of each country, Pakistan is listed at the top in both years. Let us see the domestic data of Japan. This slide shows yearly trend of crude and age standardized prevalence data of diabetes in Japan from past situation to future estimation. With men and women combined, as indicated here, 6 cohort studies and 9 national health surveys. Actually, 6 of them were Japanese National Health and Nutrition Survey were included. And as indicated, the year 2010 was employed for the population standard. As you can see, age standardized prevalence does not change much. In other words, essentially stable, while the crude rate is progressively increasing. Why does it take place? From the same data source, we calculated age group stratified prevalence of type 2 diabetes as depicted here. As you can see, the trend is fairly stable except men over 60s. And as you can also notice, the prevalence is considerably high in all the elderly subjects, that is over 60s, especially in men. These data may well suggest that the discrepancy between age standardized and crude prevalence data that I showed in the previous slide could be attributable to population aging of Japanese people. Indeed, the prevalence of Japanese people over or equal to 65 years older is currently by just a bit smaller than 30%, and this fraction is still increasing. Actually, Japan is the country that has higher aging rate than any other countries in the world, as you can see from this steep and lifted line of this chart that shows Japanese aging trend. Let us go to the next part, the second part, the outcome trials. There are a number of studies that were supported by the MHLW, namely the Ministry of Health, Labor and Welfare Japan. Among them, I would focus on one of the strategic outcome research program for diabetes, JDIT-3 trial. That was one of the three governmentally supported major interventional outcome trials. Now we enter the study scheme and the results of the JDIT-3 trial. The JDIT-3 trial, that stands for Japan Diabetes Optimal Integrated Treatment Study for three major risk factors of cardiovascular diseases, is a multi-center open-label randomized parallel group trial in which 81 medical institutions in Japan participated. The trial had two study arms that were the conventional therapy arm and the intensive therapy arm. Patients with type 2 diabetes aged 45 to 69 years old and HbA1c not less than 6.9% with hypertension and or dyslipidemia was recruited and were randomly assigned to these two arms by 1-to-1 ratio. This slide shows the treatment targets employed in the JDIT-3 trial. For intensive therapy group, the target for HbA1c was less than 6.2%. The target of blood pressure was 120 and 75 millimeter Hg for systolic and diastolic respectively. LDL cholesterol less than 80 in case of subjects with a history of coronary artery disease less than 70 milligram per DL, and HDL cholesterol not less than 40 milligram per DL were used as treatment target. Triglyceride less than 120 milligram per DL, and for body mass index BMI not less than 22 kilogram per square meter were the targets. For conventional study group, for conventional therapy group, patients were treated in accordance with the Japanese guideline as shown in the left column. The treatment targets were for HbA1c less than 6.9%, for blood pressure 130 and 80 millimeter Hg for systolic and diastolic respectively. For LDL cholesterol, less than 120 in case of subjects with history of coronary artery disease, less than 100 milligram per DL. HDL cholesterol, not less than 40 milligram per DL. Triglyceride, less than 150 milligram per DL. For body mass index, not less than 24 kilogram per square meter was used as treatment target. The chart shows randomization process of trial. 2,542 patients were randomly allocated to either of the intensive or conventional arm. 2 cases were eliminated because they turned out to be not eligible after randomization. Only less than 10% of the cases discontinued the trial in total. This slide showed the baseline characteristics of enrolled patients. The average age was around 60 years old for both groups, and a bit more than 60% was men. Duration of diabetes was around 8.5 years for either group. History of having cardiovascular disease around 11%. Body mass index around 25 kilogram per square meter for each group. Fasting plasma glucose around 160 milligram per dl. Hemoglobin A1C around 8% for both groups. Systolic blood pressure 134, diastolic 80, and LDL cholesterol around 125 milligram per dl. HDL cholesterol around 54.5 milligram per dl for either group. Median of triglyceride was around 122 milligram per dl on the whole. For these items mentioned so far, we did not see any statistically significant difference between the 2 groups. The only one thing that we found significant difference was smoking status, as shown in the 4th row. The intensive therapy group had a higher proportion of current smokers compared with the conventional therapy group. The items indicated by double dagger shows stratification factors that were used as adjustment factor for allocation. They were gender, male or female, age less than 60 years old or not, HbA1c value less than 8.9% or not, and having history of cardiovascular disease or not. That is the number of adjustment factors for allocated. That is, the number of adjustment factors for allocation was 4 in total. The median duration of the study was 8.5 years. This time period was generally speaking longer than other large-scale trials of this kind, except the UKPADS. You can see in this slide the summary data of control status for the risk factors in both groups. The blue and the red line indicate the treatment targets of the control and intensive therapy groups, respectively. In the conventional therapy group shown in blue, HbA1c did not reach the target in the mean, but the other factors reached the target. By contrast, in the intensive therapy group shown in red, only the diastolic blood pressure reached the target. Regarding the primary outcomes of the JDID-3, it was set as a cardiovascular event occurrence of any of the composite of macrovascular events and all-cause mortality as determined by an endpoint assessment committee that was unaware of group assignment. The macrovascular events were defined as myocardial infarction, coronary artery bypass surgery, percutaneous transluminal coronary angioplasty, stroke, carotid endarterectomy, percutaneous transluminal cerebral angioplasty, and carotid artery stenting. Revascularization therapy were just judged as outcomes, and the operation for the patients who were well controlled by medications or did not show severe stenosis were excluded from outcomes by the endpoint assessment committee. The secondary outcomes are shown here. The main secondary outcome, which was originally the primary outcome and we were obliged to change in the year 2010 because of a smaller number of events than expected, was a composite of myocardial infarction, stroke, and all-cause mortality. Let us see the occurrence of the primary outcomes. In total, 242 primary outcome events occurred during the interventional period. 109 in the intensive therapy group, that was 45 deaths, 5 myocardial infarctions, 15 strokes, and 44 revascularization, in which there were 5 coronary artery bypass surgeries, 37 percutaneous transluminal coronary angioplasties, and in total, 2 cerebral revascularization. One was carotid arterectomy, and one was carotid artery stent procedure. And 133 in the conventional therapy group, that was 40 deaths, 11 myocardial infarctions, 37 strokes, and 45 revascularization, in which there were 8 coronary artery bypass surgeries, 34 percutaneous transluminal coronary angioplasties, and in total 3 cerebral revascularizations, 1 percutaneous transluminal cerebral angioplasty, and 2 carotid artery stent procedures. Let us see the cumulative incidence of the primary outcome, that were myocardial infarction, stroke, revascularization, and mortality. Intensive therapy was associated with a non-significant reduction in the incidence of primary outcome events compared with the conventional therapy, with the hazard ratio of 0.81 and the p-value of 0.094. In the pre-specified sensitivity analysis, in which the primary outcome results were adjusted for baseline risk factors, the outcome was reduced in the intensive therapy group with the hazard ratio of 0.76 and the p-value of 0.042. The hazard ratio for the main secondary outcome, a composite of all-cause mortality, myocardial infarction, and stroke, was 0.74, and the p-value was 0.055. In the post-hoc breakdown of the primary composite outcome, there were essentially no difference between groups in all-cause mortality. The hazard ratio was 1.01 and the p-value was 0.95. This is also the case with coronary events. The hazard ratio was 0.86 and the p-value 0.44. However, compared with conventional therapy, intensive therapy was strongly associated with a reduction in cerebrovascular events that was mostly stroke. The hazard ratio was 0.42 and the p-value 0.002. This post-hoc finding suggests that the number needed to treat with intensive therapy to prevent one cerebrovascular event is 47.6 at 8 years. The slide shows comparison of incidence of severe hypoglycemia across large-scale randomized controlled trials. During the JD3 trial period, 7 patients in the intensive therapy group and 4 in the conventional therapy group developed severe hypoglycemia with a difference of statistical non-significance. All these patients recovered after glucose infusion or a brief hospital stay. These numbers are anyway exceedingly small compared with other large-scale randomized controlled trials. It may be not an exaggeration to say that these numbers are almost negligible. Regarding the hazard ratio of the other secondary outcomes in the intensive therapy group, they observed with a statistically significant decrease with the hazard ratio of 0.68 and the p-value smaller than 0.0001 for nephropathy. As for retinopathy, there was statistically significant decrease by the intensive therapy with the hazard ratio of 0.86 and the p-value 0.046. Let us see the harder secondary outcomes. No patient in either group had end-stage renal failure as a first event. However, 5 patients in the conventional therapy group did have to undergo hemodialysis because of end-stage renal disease, renal failure, but these had developed microalbuminuria, macroalbuminuria, or creatinine doubling prior to receiving hemodialysis. Thus, these hemodialysis events were not counted as a secondary endpoint. No loss of vision was reported in either group during the study period, and any amputations occurred in neither group during the study period. Brief summary of this part. Considering the whole data that I presented through the JDX3 part, it might be suggested that it is not a good plan for us to focus only on cardiovascular outcomes, especially myocardial infarction-related events, when conducting trials on diabetes of Japanese subjects, because of less frequent occurrence of MI in Japanese patients with diabetes. At least the merit may be ambiguous. Let us go to the last part. In this part, I will focus on the theme of standardization of diabetes treatment in Japan by introducing the standard diabetes manual for general physicians, which had been developed by the Japan Human Data Society of Diabetes and Related Diseases, for which I myself is chairing as the representative director. The manual consists of pathophysiology and diagnosis of diabetes, treatment goal, points and timing of history taking, physical examination and laboratory and ECG testing, treatment plan, hypoglycemia, complications, hypertension, dyslipidemia and obesity, and indication of the timing of reference to diabetes specialists and core hospitals. Standard Diabetes Manual for General Physicians of the Japan Human Data Society of Diabetes and Related Diseases is based on comprehensive assessment of the examinations, testing, and treatment of diabetes and its complications. Indicates frequency of examination and testing. Recommends preferred order of prescription of pharmaceutical agents. Designates indication and timing of reference to diabetes specialists and core hospitals to facilitate community-based critical path system on diabetes. Underscore evidence-based assessment of effects and safety of treatment. Make recommendation based on critical appraisal and assessment of more than 200 papers in the 2021 version. Is open to public through the web and is revised annually. This is the manual written in Japanese, and this is the recommendation for oral hypoglycemic agent classes with the order of their prescription. I do not think many of you read this. So I translated the diagram from Japanese into English. If the person had no indication for insulin, and diet and exercise therapy without pharmacotherapy is ineffective, step 1, start an oral hypoglycemic agent of the first line class, that is biguanide, namely metformin, and then in case this step fails after a few months, continuation, start an DPP-4 inhibitor at the second step. In case step 2 fails after a few months continuation, add an oral hypoglycemic agents agent from another class, that is SGLT2 inhibitors, sulfonylureas, including glinides, or alpha-glucosidase inhibitors. In case step 3 fails after a few months continuation, step 4, consider insulin therapy and GLP-1 receptor agonist or adding on of other OHAs. In that case, consider to refer to a diabetes specialist. Seeing all of these, this manual might be the simplest guideline in the world. And I would like to add one more thing, that this manual is going to be revised soon for the next fiscal year. And that time, SGLT2 inhibitors will probably be upgraded to another second-line class other than DPP-4 inhibitors, seeing recent body of evidence for cardiovascular and kidney complications as shown here. Thank you very much for your attention.
Thank you so much, Professor Noda. It is very interesting to know the trends of diabetes in Japan, outcome trials, and thanks again for sharing the example of standardization of the treatment in Japan. The high prevalence of diabetes, especially for the people at the age of 60s, especially for men, is something that we need to be very mindful about. In terms of the outcome trials, thanks again for describing the correlations between the two kinds of therapies and the kind of the outcomes. It's quite interesting to know the conventional therapy was suggested that it's maybe linked to the more strokes and also higher occurrence of end-stage renal failure. It's quite technical, but it was quite interesting for me to know that. And also you suggested that for the specialist, they should not only focus on cardiovascular outcomes, especially myocardial infarction related events, because the merit may be ambiguous. It is quite important for specialists to be aware of, I'm sure. And again, thanks for sharing the manual of standardization of the treatment of diabetes. I'm sure Pakistani side, they can make use of that and they can consider creating something similar, perhaps for them to consider. Thanks, Professor. And now we will move on to questions. And I have received a few questions. So we may, because of the interest of the time, we may not be able to get to all of the questions, but we would like to address. So the first question, let's see. So from Dr. Rashid, what is the role of trelagliptin in the diabetes management in Japan? I'm not sure if the professor, if you are aware of this. Apparently it is research in Japan, and they would like to know the role of one-weekly DPP-4 inhibitors. If you are familiar, could you address this question?
May I speak?
Sure.
Yeah. Actually, we have two types of once week type DPP-4 inhibitors, and such tablets are very convenient for people who have very limited time, and that means busy people. But when they have another types of pharmaceutical items, that is, for example, blood pressure or hyperlipidemia, dyslipidemia. Usually, in such cases, they usually take medication every day. So the usefulness of that types of drugs are very much decreased. So usually the drug once a week type DPP for inhibitors are the usually used for monotherapy for diabetes only. That's my question. That's my answer. Is this okay?
Thank you. Dr. Ashad, is there anything you would like to add, or this is okay? Otherwise,
I think
we'll move on to another one.
I have a quick comment, and again, Dr. Noda pretty much pointed out very nicely that in the regimen, when you're trying to decide about the in a patient who's recently diagnosed with diabetes, sometimes the selection of once daily is not possible. And again, the DPP-4 inhibitors have good data to support as far as glycemic control and lack of hypoglycemia evidence in this class of medication. So again, if there is a once a week DPP-4, it might not only improve the glycemia of the patient, but also will improve the compliance as well as outcome in a longer run.
I agree with you. Mm-hmm.
Okay, so the next question we received from Dr. Asif, he would like to know what is the current best treatment modality for diabetes mellitus with acute myocardial infarction. Is insulin better than metformin, or we could give oral hypoglycemic like sitagliptin and gliflozin? Would you be able to provide some inputs on this, Professor?
So I can start answering the question first, and maybe Dr. Noda can answer this further. So in any acute situation, when there's so many things going on, especially in an acute myocardial infarction, probably the best way to treat hyperglycemia is insulin. And the reason is not that the other medications don't work. The reason is that they're probably the safest in the light of there's so many medication acidosis, like metformin can be used provided there's no acidosis. The SGLT2 could also potentially cause some acidosis in few people and ketones. So I think the best treatment in any acute situation is insulin given. Control their glycemic control. Once the patient stabilizes, then you can think of changing them to oral medication. And I would love to hear from Dr. Noda, Professor Noda, if he has any additional comments.
Yeah, I completely agree with you. And in any way, in acute phases, insulin is the first choice, and in the chronic phase of MI, in all the myocardial for patients with who are having all the myocardial infarction, maybe SGLT2 inhibitors are the preferred one for such people, for such patients, I think. Okay.
Great. So probably we could take one or two more questions that we already have here. And so from Dr. Salman, he would like to know how we can adjust SGLT2 inhibitors during Ramadan, and what precautions should be given to the patient?
Okay, I can, again, it's more relevant to probably in our situation. So I will start with the answer. And Dr. Noda can add. So Ramadan would just be like any other fasting across the world, except there's degrees. People don't even drink water, like intermittent fasting and all those fasting. And there's some religious fasting across the world as well. So Ramadan is one time when people fast. And this is for Dr. Noda to have a better understanding of what the question is all about. In our opinion, SGLT2 are safe. We have clinical studies done in Pakistan on the safety of SGLT2 during Ramadan, even when they're not drinking enough water. But the rule of thumb in this situation is that the SGLT2 should ideally be taken with iftar when they break the fast and they can continue eating. And during the time that they are not fasting, they should be drinking more water. So obviously taking it at the iftar because of the diuretic and the hyperglycemic effect of it, so that whatever you're eating is covered, number one. Number two is drinking plenty of fluid while you can during the Ramadan period. And number three, if you're using it with combination, try to use it after iftar. Sahur should be left, Sahur is not the time where I would recommend SGLT2, although if you have enough water intake and if you have had a good meal, it should not be that big of a difference. But in our clinical practice, it's not only been very effective in Ramadan, but it's also very safe to use during Ramadan, provided you hydrate yourself well. Any comments, Professor NODA?
Yeah, actually, I am not so much familiar with Ramadan, so I have probably nothing to add you. I should be more specialized in Ramadan in future.
Thank you.
Okay, so if we could move on. And so Dr. Anir, he wanted to ask about the role of extended release metformin alone or in combination therapy in the management of diabetes. And from Dr. Zishan, how effective is the semaglutide once weekly injection in the management of uncontrolled DM and weight loss, whose HbA1c is 10, along with metformin, 1GBD, and then empagliflozin in 25 milligram mode. Could you address these two questions?
So actually, we do not have a sustained release type metformin. We don't have such kind of thing. But we in Japan, people they take medication with metformin usually twice or 3 times a day. But in the people with obesity, metformin is preferably the first choice for people such with big high body weight. And for regarding semaglutide, in other words, one type of once a week type GLP-1 receptor agonist. We have more than maybe three types of once a week type semaglutide injection, but it actually it is very useful for people with higher body weight to reduce the weight with the help of metformin and SGLT2 inhibitors usually. That's my figure for such the diagram for people with diabetes and obesity case. That's my answer.
So I'll add just that to Dr. NODA. I think we've summarized. So the extended release metformin is a wonderful resource, again, as we're talking about the compliance of the patient. So instead of taking metformin 3 times a day, you can technically take once daily and still get away with the treatment of metformin. It's available in Pakistan and it's used very commonly, and it's very effective. As far as GLP-1s are concerned, these are the new waves of treatment because they treat in such a different way, which is not only effective, but also takes care of the prevention of complications of diabetes. The case particularly asked by the doctor is a little interesting because the A1C is more than 10. And then they're saying if you can use a GLP-1 along with the metformin and SGLT2, you can definitely use it. The only caveat or only thing that you have to be very careful with this is that you have to make sure that this patient is not insulinopenic to extent that you could push him into some kind of ketosis. So that's something that you need to be careful. For that case, you might have to start insulin and then slowly taper off the insulin if you could do that in years to come. But again, the compliance is much better, the weight loss is much better, and the efficacy of medication is unmatched as far as once weekly dose is concerned. Thank you.
Great, thank you. And I hope all these inputs have answered your questions. And unless there's any burning questions, we would like to close this event as we already run over the time already by almost 30 minutes. So thank you again for all these attending experts. Thank you, Professor NODA. Thank you, Dr. Raza. And thank you, Ambassador. And then thank you, Dr. Ahmed as well. And we hope that this event has contributed to the further research in Pakistan and better enhanced treatment of diabetes. Thanks again. We now will close this forum. Thank you. Bye.
Thank you, everyone.
Thank you very much.
Thank you. Thank you.
For the watch of the